I am showing you two frontal chest radiographs from different patients presenting with progressive exertional dyspnea. Describe the findings.
The first chest radiograph demonstrates bilateral, multiple, small, well-defined nodular opacities, predominantly in the upper lung zones. There is also eggshell calcification of the hilar and mediastinal lymph nodes. The second chest radiograph demonstrates large, symmetric, confluent mass-like opacities in both upper lung zones, with medial migration towards the hila and surrounding paracikatricial emphysema.
State your primary diagnosis and the clinical terminology used to describe the confluent masses in the second patient.
The primary diagnosis is silicosis. The large confluent masses in the second patient represent progressive massive fibrosis, which is characteristic of complicated silicosis.
If I tell you both patients had long-term occupational exposure to sandblasting and stone masonry, how does this guide your diagnosis?
With that specific history of occupational silica dust inhalation, the diagnosis of chronic silicosis is confirmed, showing the spectrum from simple silicosis with eggshell calcifications to complicated silicosis with progressive massive fibrosis.
What is the defining threshold on imaging that differentiates simple from complicated silicosis?
Simple silicosis is characterized by nodules measuring between 1 and 10 millimeters in diameter. Complicated silicosis is defined by the coalescence of these nodules into progressive massive fibrosis masses measuring greater than 1 centimeter.
Explain the calcification pattern seen in the first radiograph and its diagnostic significance.
The calcification is a peripheral, ring-like pattern along the capsules of the lymph nodes, known as eggshell calcification. While classically associated with silicosis, it can also be seen in coal workers' pneumoconiosis and sarcoidosis.
Describe the typical lung zone distribution of simple silicotic nodules.
The nodules typically show a marked upper lung zone and posterior distribution, which correlates with the inhalation and deposition patterns of silica particles.
What histopathological features define a silicotic nodule under light microscopy?
Histopathologically, a silicotic nodule consists of a central acellular area of necrotic collagen, surrounded by concentric whorls of dense collagen fibers. Under polarized light, birefringent silica crystals can be identified.
Describe Kaplan's syndrome and its classic radiological findings.
Kaplan's syndrome is the combination of a pneumoconiosis, such as silicosis, with rheumatoid arthritis. Radiologically, it presents as multiple rapidly developing, well-defined necrotizing nodules, typically in the lung periphery.
Why are patients with silicosis at a significantly increased risk for pulmonary tuberculosis?
Inhaled silica is toxic to alveolar macrophages, impairing phagolysosomal fusion and compromising cell-mediated immunity. This leads to a 30-fold increased risk of developing active tuberculosis, or silicatuberculosis.
State the critical safety warnings and management recommendations if one of these masses demonstrates cavitation.
The critical safety warnings are active silicatuberculosis, which is highly infectious, and coexisting bronchogenic carcinoma. Radiologists must immediately recommend placing the patient in airborne isolation, suggest sputum smears and PCR for Mycobacterium tuberculosis, and advise a chest-computed tomography scan to rule out cavitating infection or malignancy. Refer to pulmonary medicine